Thank you so much for listening to this presentation, and I want to thank the organizers for the opportunity to present the work of the Opioid Task Force. My name is Micki Reinhorn. I am a hernia surgeon in the Boston area. I'm going to tell you a little bit about what our task force has accomplished to date and why there's some urgency to change our practices even now. Disclosures: I've been a consultant for Reinhorn Therapeutics. They are developing a long-term local anesthetic. So why is it important to continue talking about opioids? We know that 1 in 16 patients that's giving a post-operative prescription becomes dependent or addicted to opioids for at least 3 to 6 months. We have all seen this data. It's in the news. It's in front of us all the time. But what does it have to do with me? Many of us feel that we're already doing better. Headlines like this: while addiction crisis raged, many surgeons overprescribed opioids, the analysis shows, seem outdated. The data is from 2011 through 2016. This was published in 2019. I think all of us feel like we're doing better. Yet, our data says otherwise. The ACHQC created an opioid module designed to track patient use and surgeon prescribing information. We started collecting data in March of 2019, and this is the initial data that we collected. On the y-axis is the number of patients. On the x-axis is the number of tablets that were either used or prescribed. So 0, 1 to 2, 3 to 4, a range of 5 to 10, 11 to 15, 16 to 30, and more to 30. In red is what surgeons prescribed for incisional, umbilical, and inguinal hernia. In blue is what those same patients actually took in terms of tablets. What's striking is even the most motivated surgeons within the QC, within the task force, who reported their data voluntarily, still overprescribed opioids compared to what our patients were taking. So why is it important to us? Why is it important to you? Why is it important to me? I was overprescribing even in 2019, despite doing my best efforts. And so in December, at the Quality Improvement Summit, we asked surgeons who were in attendance to change their prescribing. We asked them to do 2 things. We asked them to adopt a multimodal analgesia pathway for their patients, and as part of that, to prescribe 10 tablets or less for umbilical and inguinal hernia. And how did we do? In 2019, the table here shows that the mean number of tablets prescribed were almost 14 with a standard deviation of 7. Yet when we moved to 2020, we're down to 10 tablets as the mean and only a 5 standard deviation. The total N is lower in 2020 because of COVID. We're just not doing as many and didn't do as many surgeries. I think the most fascinating finding here is that while the median number of tablets prescribed didn't change from 10, the interquartile range changed from 12 to 2. It means we are much better at prescribing 10 tablets or less, and very few of us are prescribing more. So based on this data, how did our patients do? Well, in this graph, I show the number of tablets that were used by the patients from 0 all the way up to 30. And then in green, we show the 2019 data. As you can see on this side of the graph, there's still quite a few number of patients, almost 20%, who used more than 11 tablets after umbilical hernia surgery. But in purple, we have the 2020 data. We have shifted the curve to the left. Our patients are using less opioids. In fact, less than 10% use more than 10 tablets. And even more patients use none. So clearly we have had an impact on both the prescribing and our patients, thus taking tablets off the street. So we're making a difference, but now we need you to take a more active role in reducing the number of tablets prescribed. So what can you do? I think the simplest two things are join the America's Hernia Society if you're not a member already. And if you are, join the ACHQC. It is an incredibly welcoming group of surgeons who are motivated to do better for their patients. It's been a wonderful experience to be in the ACHQC and to collect the data. I think it is critical to collect our own data, both what we're doing in terms of the surgery we're performing, what we're prescribing, and then following that up with what the patients are taking for opioids. There is nothing more powerful than looking at our own data and finding opportunities to improve and grow. Once you're collecting data, then there's an opportunity to educate our patients, to educate ourselves more about multimodal analgesia, which I'll get to in the next slide. Finally, consider using opiates for breakthrough pain only whenever possible. So the ACHQC has made it relatively easy for you to learn the information required to teach our patients. The first bullet point is a link to the Opioid Initiative webpage. It goes through what we've done as a task force. There's also links to previous talks that have been given and tools for our patients. In fact, the other link here is a note card, which I have on the right-hand side. It's designed to provide to your patients as part of the counseling. When reviewing this note card, you can really see that there are opportunities for changing the way we take care of patients. For example, giving ice after surgery for the first 24 hours. Tylenol and Advil are the first line medications recommended. And it turns out it doesn't make a huge difference whether they're prescribed or recommended, whether they're given every 6 hours together or alternating every 3 hours taking something else. It's equally effective, but it's important to educate our patients that these are really the first line approaches. Finally, an opioid is really the rescue medication that should only be taken for more severe pain. And letting our patients know that the data supports them not taking opioids for this operation. So there's a lot of information out there through the ACHQC. If you have any questions, you want to learn more, we have a very robust task force, all motivated, welcoming surgeons who have worked really hard, both dedicated their time and energy to improving prescribing habits and use of multimodal treatment. Reach out to any one of them or reach out to me. My email is below. I want to thank you for the opportunity to do this, and please reach out if you have any questions. Thank you.